The following podcast is part of a certified educational activity titled Ensuring the Rapid Recognition and Optimal Management of Hemophilia in the Emergency Department, the Role of Inclusive Decision-Making. Access the entire activity and complete the post-test at peerview.com/QUN860. Downloadable slides and practice aids are also available.
Hello, and thank you for joining us on a discussion that focuses on how to ensure the rapid recognition and optimal management of hemophilia in the emergency department, with a special attention to the role of inclusive decision-making. This online educational activity is designed for an audience of emergency room physicians and nurses, and the activity will be divided into 3 segments. The first will focus on evolving therapeutic landscapes in hemophilia, and then we'll move on to how best treat hemophilia in the emergency room, highlighting what the current guidelines are. And then finally, we will end with a case-based discussion from our expert panel to understand best practices and how to incorporate shared decision-making into the management of hemophilia. My name is Dr. Anita Rajashekar, and I'm an adult non-malignant hematologist at the University of Florida. Joining me today in this discussion are my colleagues at the University of Florida, Dr. Brandon Allen and Dr. Tung Nguyen.
Thank you for having me today.
Thank you for inviting me to participate in this talk.
Okay, excellent. Let's begin by understanding what the current landscape is and recent advances have been in the management of hemophilia. So by way of background, congenital hemophilia is one of the most well-known and studied inherited bleeding disorders. Hemophilia affects secondary hemostasis since it involves a deficiency of the clotting factors, namely factor VIII and factor IX. It's an X-linked inherited disorder, so predominantly affects males, and mothers and daughters are obligate carriers of inherited hemophilia. You'll see by these statistics on this slide that hemophilia A is more common than hemophilia B, and that's because factor VIII is larger and more susceptible to mutations than factor IX.
Yeah, Dr. Raj, this is certainly a rare event in emergency medicine. However, it's not a never event, and knowing the intricacies of this disease process and how to manage it are going to be vitally important for morbidity and mortality of these patients.
And it's really important to understand the bleeding phenotype in these patients, and it varies across spectrums. So the variability really depends on the factor level in an individual patient. So you'll see here on this slide that in mild hemophilia patients, which is defined as a factor level between 5 and 40%, they generally have very few bleeding problems unless they're challenged with surgery or major trauma. Moderate hemophilia patients, on the other hand, have lower factor levels, somewhere between 1 and 5%, and they tend to have moderate phenotype of bleeding and do tend to bleed after minor trauma. And then you have our severe hemophilia patients who have a baseline factor level less than 1%. In these patients, they can have severe hemorrhage, most commonly into the joints and muscles, and they can present very early in childhood, and often they have spontaneous bleeding without any trauma. It's really important to note also that our mild and moderate hemophilia patients may not be diagnosed until later in life when they actually have a hemostatic challenge. So while life-threatening bleeds can happen with hemophilia, especially severe hemophilia, the most common bleeds are in joints and muscles. And when we see recurrent bleeding into the same joint, we term that joint a target joint. And eventually that target joint can be affected by chronic synovitis and progressive degenerative changes of the cartilage and bone. Over time, this can lead to end-stage joint damage with significant pain and range of motion deficits, and eventually these patients may require surgical interventions such as joint replacement or fusion.
Yeah, Dr. Raj, in this case, I've certainly seen the majority of cases being hemarthroses and the significant disability that can happen with the target joint, as you referenced.
And many of my patients in the adult clinic, I have to end up referring them to the orthopedic surgeons, and they discuss what options exist in terms of replacement and fusions. So it's certainly a significant morbidity for these patients who are having recurrent bleeds in their joints.
And definitely a high-risk surgery as well, where it can be quite complicated perioperatively.
Absolutely. So the National Hemophilia Foundation has the Medical and Scientific Advisory Council, or MASAC, and they issue periodic recommendations and advisories on treatment, research, and other general health concerns for the hemophilia community. Factor prophylaxis is a regular infusion of factor concentrates in order to prevent bleeding. And the idea of prophylaxis comes from the observation that people with moderate or mild hemophilia who have factor levels over 1% rarely experience spontaneous bleeding. So based on that, MASAC has issued recommendations on prophylaxis as the standard of care and optimal therapy for individuals who have severe hemophilia. Prophylaxis should be instituted early and ideally prior to the onset of frequent bleeding, and the goal is to keep the factor level above 1% between doses to prevent bleeding. Now, optimal dosing and frequency should be determined for each individual, and that is an individual case-by-case decision based on appropriate lab monitoring. So the bottom line is that it's not a one-size-fits-all in terms of the factor prophylaxis regimen. And then finally, MASAC recommends that individuals on prophylaxis should have regular follow-up visits to evaluate joint status, to document any complications of factor infusions like inhibitors, which we'll talk about, and to record any bleeding episodes that occur while on prophylaxis. So it's clear that prophylaxis is not a static treatment, and a patient's regimen may change over time. Dr. Nguyen, I've found this guidance that MASAC gives us particularly helpful when I'm talking to patients. And I'm curious, do you use these recommendations in your day-to-day discussions in clinic with your patients?
Yeah, I would add that beyond the MASAC guidelines, there are well-established studies that show the early and aggressive use of prophylaxis can delay and, in many circumstances, prevent the development of the joint complications that you're discussing. And these MASAC guidelines, as well as the numerous studies that exist, I use to discuss with my patients about when, how, and what form that may take.
Okay, we're going to transition into the potential barriers to the optimal management of hemophilia in the emergency department. This is something, as we mentioned, that is a rare disease, and you may want to ask yourselves in your current emergency department setting, what is the number of these that you potentially encounter? And also, what kind of resources you have at your disposal when you need something with these patients. The great thing, though, is that hemophilia patients are very knowledgeable about their disease state, and these can routinely be managed at home with specialized treatment centers as a consultant prior to heading to the emergency department. But however, they do present in emergent situations, and expanding the number of available treatments is also something that has to be in consideration, where does your hospital stock the medicine, or is the expectation that the patient should have it? And sometimes you have to go kind of off formulary, but we're going to discuss that a little bit more in future slides in regards to the approach to this to keep the patient in the best scenario of wellness.
Yep, Brandon, I agree. I think this is mostly an outpatient disease, thankfully, which is probably why many ER providers don't have a lot of experience with it. I think it's really important for ER providers to remember that patients really know a lot about their disease for the most part and know what works for them. And so when they come in and give you a history and tell you, this drug has worked for me, this has not worked for me in the past, this is the dose that works for me usually, I think it's important to believe that they know that and to really trust the patient from that standpoint. Sometimes patients, as you mentioned, bring their own medications. Other times, especially in our mild and moderate hemophilia patients, because they don't either know how to self-infuse or don't need to self-infuse much because they don't bleed often, they don't have drug with them, and so we end up having to use whatever is on the hospital formulary. So it is important to know what's on your hospital formulary and how to dose that.
Great points, Dr. Raj. I couldn't agree more that one of my first things I do in an encounter with a hemophilia patient is to ask them about what they do at home and what they've done in the past that's worked for them to get out of one of these potential emergent situations.
Well, let's move on to what the evidence is for routine prophylaxis. And Dr. Nguyen, you alluded to these studies. There have been a few studies that have looked at the benefits of routine prophylaxis. The one that many are familiar with is the joint outcomes study. And that was the first study to really show us that prophylaxis with regular scheduled factor infusions reduced joint bleeds, joint damage on imaging studies, and really led the way for this strategy to become the standard of care in severe hemophilia patients. This study was then confirmed by the ESPRIT study, which found that prophylaxis was particularly beneficial in preventing joint damage when started early. And then finally, a similar study documented the benefits of prophylaxis in hemophilia B patients as well. So Dr. Nguyen, I know in my adult hemophilia patients, despite this evidence that shows a benefit to regular prophylaxis, I still see a lot of hesitation on the part of infusing themselves several times a week, and understandably it's burdensome, it's expensive to give 2 to 3 times a week infusions. Do you find resistance in this approach in your pediatric patient population?
In the pediatric population, especially the youngest population of toddlers and newborns, the most difficult challenge is IV access for these patients, and the resistance comes in how can we establish the most accessible IV access for them. Generally, patients are very, very compliant in pediatrics because the administration of the factor is provided to them at an early age, either by a home health nurse or by the parents themselves. But oftentimes, as we transition to self-infusion, where the patient learns and provides the factor for themselves, the challenge becomes maintaining that compliance to the prophylactic recommendation. And the adolescent and teenage population in our practice do face challenges similar to the ones that you're describing in adults.
And that's why it's really important, again, to involve the patient in the decision process and really practice shared decision making, because it's really not helpful if we prescribe something and ultimately on the patient side they're not going to take it. We have to have buy-in from them for this prophylaxis regimen. So what are the other hurdles of prophylaxis and optimal management of hemophilia? Unfortunately, replacement of the missing factor with factor concentrates is short-lived with the traditional standard half-life therapies. Factor VIII's half-life is about 8 to 12 hours, and Factor IX half-life is about 18 to 24 hours. So this really translates into a burdensome regimen of 2 to 3 times per week factor infusions for prophylaxis to keep a patient above that over 1% and prevent bleeding. Another challenge in the treatment of hemophilia is the dreaded consequence of inhibitor formation. And inhibitors are these neutralizing antibodies against exogenous factor that is infused, rendering standard factor replacement ineffective.
Dr. Rajashekar, I would also add that the vast majority of inhibitors, when they develop in young children, infants and toddlers, and usually those patients are within the first 50 doses, the first 50 exposure doses in their lifetime.
That's right. So by the time they come to me in my adult clinic, often they've already developed an inhibitor. Often they're already on a very good regimen that works for them. So it really is the pediatric hematologists that have the burden of diagnosing and treating these diseases early on. So what are the factors that influence inhibitor development? There's a variety of them, and while we can't predict who will ultimately develop an inhibitor, there are risk factors that help us understand who might be high risk, and these are outlined here. These include patient-specific factors on the left-hand side and treatment-related factors on the right-hand side. And there's a lot of work being done in this area to try and predict and minimize the risk of inhibitor formation, but ultimately it's a complex interaction of many variables that leads to inhibitor development in any individual patient. Okay, so let's discuss what options exist for hemophilia treatment currently. To remind everyone, there's been an evolution of products over the years. Initially, we had plasma-derived factor concentrates that were introduced in 1969, and they've really come a long way in terms of safety with modern methods of purification. Then came along recombinant or genetically engineered factor concentrates, and these were really developed as a response to the HIV and hepatitis epidemic in our hemophilia patients in the 1980s. The third and fourth generation recombinant products have no human or animal protein in the final preparation of the product. And then there are differences in protein structures, including B domain deleted and truncated versions of the product compared to full-length factor molecules. Among the standard half-life products, half-lives do not really vary significantly, with the mean half-life of about 12 hours for factor 8 products and 24 hours for factor 9 products. So again, this really translates to rather frequent infusions for our patients based on these half-lives. So in the past 5 years, there's been really an explosion of new therapies available in the pipeline for hemophilia treatment. And to address the burden of factor 8 and factor 9 prophylactic infusions, these extended half-life products were developed. Here you'll see a list on the left of those that are approved for hemophilia A and B, and we've listed here both the generic and brand names, since most of our patients and providers in the ED will be familiar with those brand names. The last product here is a new generation factor 8 product that circulates independently of von Willebrand factor, and so it breaks that von Willebrand factor imposed half-life barrier. Phase 1 results with this product have been really encouraging, and the half-life has been on the order of 40 hours with weekly or every 10-day dosing. On the right side, we have a list of all the newly approved products and investigational products that Dr. Nguyen will be reviewing shortly in the next section of this presentation.
Dr. Raj, these are certainly names that I think every emergency physician would struggle to pronounce, and I want to underscore the fact that you may not know the exact name of these or what it's for, but knowing where to gather that information and who to discuss from a specialist standpoint is probably of the utmost importance for the emergency physician.
Absolutely. Thanks, Dr. Allen. So now let's talk about the mechanisms by which we can extend the standard half-life product's half-life to an extended half-life product. There are three main mechanisms by which we can extend the half-life of factor concentrates. The first is FC fusion, and this was the first extended half-life technology on the market. Here what we have is a fusion of the FC portion of IgG to the factor molecule. And this promotes half-life extension by altering the normal clearance of the factor. So what you have is the factor 8 molecule linked to the FC IgG, and that complex then is recycled back into circulation rather than being directed to lysosomal degradation within a cell. The second method of extension of half-life is pegylation. And what we're doing here is they attach a covalent PEG product to the factor molecule itself, and that protects against proteolytic degradation, thereby reducing the clearance and increasing the half-life of the product. Essentially, PEG creates a cloud around the factor, making it too big for the kidney to clear. And the third method of extending half-life of a factor product is through albumin fusion. And here the half-life extension builds on the long half-life of albumin itself, which is attributed to its high molecular weight, and also to the pH-dependent interaction with the neonatal FC receptor, which then in turn prevents the intracellular degradation. So these are all methods of extending the half-life of products, and we've had quite good success with these newer products. So here you'll see that there's a list of various extended half-life factor 8 products on the market. What you'll notice here is that with the current methods of extension, it really has not been a home run. We've been able to extend the factor 8 half-life of the product by at most 1.7-fold. And this is largely because, like native factor 8, the half-life of extended half-life products are regulated largely by the interaction with von Willebrand factor. So consequently, the half-life of von Willebrand factor, which is about 15 hours, has been the limiting factor to factor VIII products being extended in their half-life. So what I think is important to know that these products are available, that patients are asking about them, and patients are presenting to the ER on these new products. So I think it's important for ER physicians and nurses to be familiar that these exist.
Dr. Rajasekhar, I think it is also important to note that the half-life extension is very variable between patients. So some patients may have 19 hours, but some patients may have, a large variance from that, and a large portion of patients may have much shorter half-lives, and some may actually have a slightly longer half-lives.
And that's particularly true for your pediatric patients, where clearance often with these products is much quicker than our adult patients. So in general, the pivotal data that led to FDA approval of these extended half-life products are based on studies that compared the product using regular prophylaxis with the extended half-life product and comparing it to on-demand standard half-life products. And most of these studies found that with regular prophylaxis with these newer products, we had a reduction in annual bleed rate, or ABR. So you'll see that the prophylaxis with these agents is much less frequent. It also had good success. And in those that developed a bleed and had to take more factor, typically it only required 1 or 2 doses of the extended half-life product to resolve the bleed. Finally, from a safety standpoint, which we obviously need to consider, is the inhibitor formation. And from these studies, you'll see that there was either no inhibitor formation or very rare incidence of inhibitor formation. So unlike extended half-life factor VIII products, we've had much more success with extending factor IX half-life drugs. And so what you'll see here is that there are a few factor IX extended half-life products where their half-lives have been extended up to 5 times the standard half-life product. Now, Dr. Nguyen, in your experience, because of this significant prolongation in half-life with the factor IX products, has there been more enthusiasm in the hemophilia community about switching patients from standard half-life factor IX products to these extended half-life factor IX products?
Yes, and for all the reasons that you stated, our pediatric patients have been very enthusiastic in switching from a standard half-life factor IX product to an extended half-life factor IX product. The factor VIII uptake has been a lot slower because the increase in half-life has been more incremental in its nature.
Right. And with the improvement in convenience with these extended half-life product, it's really important to make sure that they're still efficacious. And so you'll see here that there have been several pivotal trials leading to the FDA approval of these factor IX extended half-life products that have shown not only a reduction in annual bleed rates with regular prophylaxis, but also for those who have a bleed, they typically, again, only require 1 to 2 doses to control the bleed. And here, in terms of safety, there were no inhibitors that developed in these studies. So we've spent a lot of time talking about patients without inhibitors and the multiple drugs that are available, standard half-life products, extended half-life products for these patients. But for patients with inhibitors, infusion of factor concentrates is generally not effective. And so limited options exist for these patients, and they include bypassing agents. The purpose of a bypassing agent is to provide essentially a detour to bypass the factors in the coagulation cascade that are blocked by the inhibitor to help generate a fibrin clot. And the 2 available bypassing agents that we use mostly in inhibitor patients are recombinant activated factor VIIa and prothrombin complex concentrates. Dr. Nguyen will be discussing advances in treatment options that are particularly exciting for patients with inhibitors in whom we've had very few options over the years.
This is something that really could be problematic for the emergency physician when you provide the factor replacement as thought would work, and then you're still running into a potential emergent condition that could require an intervention. And making decisions with these medicines, which are quite expensive and not benign themselves, is definitely going to take some shared decision making with a specialist.
And it's important to note that the presentation of an inhibitor may be for the first time in the ED. So it may be that the patient doesn't know they have an inhibitor. They've just been noticing over time that their factor is not working as it previously had, or they're having more bleeds, and they finally come into the ED, and there has to be a high clinical suspicion to look for these inhibitors. Okay, so now I'd like to turn over the presentation to Dr. Nguyen. Dr. Nguyen, I'm very excited to hear about some of the novel therapies that are coming down the pipeline in the hemophilia space.
Thank you, Dr. Rajasekhar. It's my pleasure to talk about these new products. As you mentioned at the beginning of your lecture, these are very, very exciting times in the world of hemophilia, and the introduction of new products and these products, which are what we consider novel products, is coming very, very quickly. It becomes important to have expertise to keep up with all of these introductions. So the first and the currently approved novel agent is a product called Emisumab. The Emisumab is a bispecific monoclonal antibody that acts as a bridge between factor 9 and factor 10 to replace the factor 8 product. Very, very shortly, we will begin using additional agents. Fitusiran is in late development, as well as a product called Consismab. And very, very exciting, all of us are expecting gene therapy to be on the horizon and will be a therapeutic product that patients will be utilizing. So first of all, Emisumab, like I mentioned, is a bridging agent. So it acts, in replacement of factor 9 by bringing factor 8, by bringing factor 9 in close proximity with factor 10, and because of the proximity on the phospholipid membrane, they will go ahead and interact and lead to further activation of factor proteins to eventually develop fibrin clot. The studies that support the use of Emisumab, are the Haven series of studies, the 1 through 4. So starting with Haven 1, Haven 1 looked at patients who have inhibitors and how effective it was in the control of bleeding. And the results from Haven 1 show that unlike bypass therapies that these patients were on, Emisumab can reduce annual bleeding rates by more than 90%. Haven 2 was a follow-up study for those patients, and this was a pediatric study looking at its use in the same population, and Haven 2 showed similar results compared to the reduction in annual bleeding rates that were provided to adults. The Haven 3 study looks at the use of Emisumab in the prevention of bleeding for patients who do not have inhibitors. And similarly to the Haven 1 and Haven 2 studies, the results do show also a reduction in annualized bleeding rates to greater than 90%. And then finally, Haven 4 looks at alternative dosing regimens for Emisumab. The dosing regimens previously approved were to be given once a week, and Haven 4 establishes the use of Emisumab dosing once every 2 weeks or once every 4 weeks, and alternative regimens are equally effective to reduce bleeding rates for adults and pediatric patients.
And Dr. Allen, I think what's important for ER providers here to know is that this is becoming widely used in our hemophilia population, that you will be seeing patients on this new medication, and that it's used for prophylaxis, not to treat a bleeding episode. So if a patient on Emisumab comes to the ER and has an acute bleed, you would revert back to using their factor 8 or 9 product if they are a factor 8 product if they're a non-inhibitor patient, or a bypassing agent if they're an inhibitor patient.
These are great points, Dr. Raj and Dr. Nguyen. Knowing about these is probably going to be half the battle with recognition, as you mentioned, and into your treatment strategy, where that shared decision making that we're going to discuss quite a bit in the near future is going to be paramount to their success in improving morbidity and mortality.
The other major advantage of Emisumab is that it is administered in a subcutaneous fashion, rather than an intravenous fashion, so it is much easier for our patients to learn and perform the infusions.
And Dr. Nguyen, I imagine that probably improves their quality of life as well.
It improves their quality of life, both because of the route of administration and the frequency of administration, and it has actually increased the compliance of our patients who have switched to it because of those factors that ease its use.
And then finally, from a safety standpoint, we are really happy to see that this medication is not associated with inhibitor development.
So moving on from Emisumab and to other non-factor products that are in development and hopefully soon to be approved. Another exciting one is a product called Fitusiran. Fitusiran is a product that uses interference RNA, a short snippet of RNA sequence that will block the production of antithrombin 3, by preventing its translation into a protein. So it represents, a type of therapy that rebalances the hemostatic system rather than directly replacing the factor that is missing. It will reduce the counterbalance to coagulation and putting clotting and bleeding into a more even balance. So the development of Fitusiran has been years in the making, and currently the process of development has Fitusiran in phase 3 trials. The trials are showing good results with good bleeding control, and the most exciting thing is that Fitusiran is a therapy that will be not limited to just factor 8 patients, but also can be used to manage the bleeding of factor 9 patients as well. The next agent that we wanted to discuss is Consisumab. Consisumab is similar to Fitusiran in that it hopes to rebalance the coagulation system rather than just simply increasing a missing factor. The mechanism of action of Consisumab is to block a molecule called tissue factor pathway inhibitor, and allowing the production of factor 10 in the production of the fibrin clot. Consisumab also is in development. It is currently in phase 2 trials, and so far it has shown good results. There are concerns currently of related thrombotic events that have the most recent studies on hold, but those patients hopefully will be starting up real soon once the events have been clarified. And then moving on to the most exciting new therapy that providers as well as patients have been hearing decades about is gene therapy. So gene therapy, unlike any of the other factors, looks to restore normal factor production in our patients. So the current generation of gene replacement therapy uses a virus vector called AAV, which has the inability to reproduce itself and is able to be modified to carry a gene to be the template for production of the factor. So the virus will be injected into the body and carry the gene to a producer cell, which is typically a cell in the liver, and the DNA will be uptaken and will exist in the nucleus, and the new DNA will use the nuclear mechanisms to translate itself and produce the factor VIII within the patient's own body. The cells, being living cells, will continue to produce the factor over an extended period of time. So the gene therapy products that are in development, are ongoing. The factor production for these patients have shown that has been effective. It has reduced bleeding rates in men who have received the product and have produced stable rates anywhere from the 20 to 40% range. Some of the studies are still ongoing and the products are still being developed. The BMN product will probably be the first of many products to come to be introduced. Gene therapy also has its limitations. So the AAV vector, it has a limited lifetime. So the production of factor, is expected to decrease over time as the cells live their own lifespans. We also know that gene therapy is a single dose treatment at the current time because it is a virus vector. The immune system will develop an immune response against the virus, and the reintroduction of the virus will cause a destruction of the carrier molecule without any uptake into the producer cells. Hopefully, with those obstacles, we will be able to address them and overcome those with the introduction of even newer products.
And Dr. Nguyen, it strikes me as important as you're talking about these new pipeline drugs and gene therapy that if a patient on one of these clinical trials presents to the ER, whether it has to do with bleeding or something else, that it's important for ER providers to then contact the institution, the principal investigator, or the study coordinator to let them know that a clinical trial patient is in the ER, and so that we can investigate whether this adverse event is related to a product.
That is right, Dr. Rajashekar.
This is very interesting, Dr. Nguyen and Dr. Raj. I think the awareness of the emergency physician, as you mentioned, and speaking with the study coordinator or PI would be incredibly important, because there also may be some other mitigating factors to severity of illness based off of the study, outside of just the recognition and documentation of a potential event. And I think calling a hematologist in these situations is of the utmost importance to start therapy if anything could be different that's more in their specialty.
So next, I would like to go ahead and have Dr. Allen present the approach in the emergency department for our patients.
Thank you, Dr. Nguyen. So we're going to talk about what do the current guidelines tell us for the treatment of hemophilia in the emergency department. This should be right in our wheelhouse in regards to the approach, evaluation, and management of these patients. And first, we're going to start out with the National Hemophilia Foundation MASAC guidelines. And some of these things, if there's any two take-home points I want you guys to know from this, is when in doubt, give factor, and treat first, image or diagnose second, are two things that have really been the standards and the major highlights of these guidelines. And first, you start out with triage, of course. If someone's to arrive to the emergency department either by ambulance or into your lobby, they should be urgently triaged if they have a history of hemophilia. Delays in administering factor can significantly impact their outcomes with morbidity and mortality. And the other big take-home point on this little checklist that we have here is urgent and early consultation with the hematologist or a regional center or professional is strongly advised. But that doesn't take away the responsibility of the emergency physician to perform an appropriate medical screening examination and get therapy started quickly. That leads us into the assessment of the patient. And we're going to do a great clinical history. As mentioned before by Dr. Raj, it's really important in this that the patient is incredibly knowledgeable with this disease state. And with that comes a lot of help to the emergency physician in regards to what they tried at home, what they know about their factor replacement, do they have any with them, things like that. And it's also important to point out that in your physical exam, it could be normal in the early phases of someone's potential emergency. And that in severe disease states, as we're going to talk about in a couple slides on a really nice table, spontaneous bleeding can occur without trauma. I think one thing that's a little bit of a pitfall for emergency physicians is to think that a hemophilia patient may require trauma to have a potential injury, and that's potentially not the case in these severe disease states. This goes back to this the big piece of this slide, which is when in doubt, administer replacement and do not delay for imaging studies, labs, or consultations. And I think this is the best way for us to have better outcomes for our patients.
And Dr. Allen, if I can just interject here, I think we talked a little bit about when a patient brings clotting factor concentrate with them, it's generally best to allow them to use that concentrate if at all possible. And this recommendation really acknowledges that many emergency rooms, especially at smaller hospitals, do not have the majority of clotting factor options and may not have any clotting factor for that matter on their formulary. And then the other piece is, you mentioned that you should infuse factor before imaging and labs, but if a patient is being transported to your ED or transported from your ED to another facility for a step up in care, again, it's really important to infuse before that transport.
Those are such great points, Dr. Raj. And one of the realities of this too is that these factor replacements are expensive. And pharmacies at your local hospitals or in your emergency departments may not carry the exact one that the patient may have, but they may have one. And if not, then a referral and transport is of the utmost importance to get them what they need. Moving on into diagnostic studies. And there's some do nots on here that I think are incredibly important for resource utilization. And one thing that we talked about earlier was a target joint and hemarthroses, and routine bleeding in those joints do not require imaging. I think that actually is tough to manage in an emergency department setting, especially if they have decreased range of motion and things like that. But that's a part of those MASAC guidelines that I think they're important to point out. And back to what we were talking about earlier, clotting factor replacement should always supersede any diagnostic studies, especially in the cases of trauma. There are frequent cases of minor trauma that can result in intracranial hemorrhage and abdominal trauma that can result in intra-abdominal injuries and hemoperitoneum.
And Dr. Allen, it seems like what you're saying here is that treatment decisions really should be based on the suspicion of a bleeding-related problem, not a documentation necessarily of one. And that kind of goes into what you were saying about labs and imaging not being required. Frankly, labs are not expected to guide management, and factor levels are not often available in real time. So it's not really feasible to check some of the specialized labs to guide your treatment decisions.
I couldn't agree more. And another thing that we haven't really touched on is invasive procedures that are very common in the emergency department. There's some examples like a lumbar puncture, arterial blood gas or an arterial line, and lung or thoracentesis or even arthrocentesis or a joint tap that, or if major surgery or emergent surgery is indicated, it's paramount that you replace and raise that patient's level to 100% in the ED prior to the procedure, or the risk of complications and hemorrhage increases substantially. This is a nice summary of the MASAC guidelines for ED management, and I think a lot of these indications for factor replacement are self-explanatory, and just go ahead and peruse yourself through this list, and we'll move on to the actual management and treating of the patients. I think one thing that's outside of the remembering of the treat first, diagnose later is about minor, moderate, and severe indications for factor replacement, and then the target percentage of correction. As it states here, these are really nice criteria of where you get into the severe, the moderate, and the minor. And for the severe, I think we should focus on things that regard to the central nervous system, areas where you can have expansion of blood in a space like the retroperitoneum, the retropharynx, which could be quite scary for an airway, and any type of surgical or GI, as we mentioned on the last slide. And then in the moderate, you get into the hemarthroses, potentially the target joint, dental, and anything to do with hematuria or muscular. And then the minors, obviously, the more mild cases of such. I don't expect emergency physicians to memorize these things, but having to know where to reference this is going to be important for you to be able to manage first and do that treat first strategy.
And Dr. Allen, there are online calculators that can help calculate what dose to give.
We love online calculators. That's great.
Dr. Allen, one thing to remind everybody is that these patients are oftentimes on prophylactic regimens, as well as they have the ability to self-infuse themselves, and sometimes they have levels that are pre-standing. Another rule of thumb to keep in mind is that if these patients have ongoing treatment, if you don't know what the level is, go ahead and treat to the full intended level that you want and assume that the patient is at 0%.
Thank you, Dr. Wynn. That's a great rule of thumb. When in doubt, assume that they're at 0. I think we'll be able to really standardize that. Moving forward, there's this challenge with Hemophilian inhibitors that's worthy of a discussion with the ED management. And this brings in another piece of complication, and we discussed this a little bit earlier, but this is the patient who may be refractory to your initial factor replacement. And this is where a hematologist, in discussing with a specialist, is paramount to the patient's success. And if someone presents with an inhibitor or a presumed inhibitor and has a life or limb-threatening scenario, the two options that we have at this point in time are factor VII or prothrombin complex concentrates. And this would certainly be a shared decision-making, in my opinion, with a specialist to talk about the risks and benefits of both of these, and also the capability of your institution to be able to provide one of these, hopefully. If not, you will certainly need to transfer the patient to a higher level of care.
So Emisumab is solely used for prophylaxis or prevention of bleeds, and we touched on the fact that if a patient on Emisumab comes into the ED with a bleed, we should be treating them with factor concentrate in the case of non-inhibitor patients, or a bypassing agent in the case of an inhibitor patient. The one caveat to that is that recombinant factor VIIa is recommended over FIBA, one of the prothrombin complex concentrates, and that's because in clinical trials, prothrombin complex concentrates were noted to have a higher incidence of thrombosis or thrombotic microangiopathy when used in combination with Emisumab prophylaxis.
So the thrombotic complications of factor choice with Emisumab is well noted. There have been thrombotic events that have been reported when providing acute management for patients on Emisumab. The incidence of thrombosis have been defined as when patients have received an activated prothrombin complex concentrate at high doses, generally greater than 100 units per kilogram in a 24-hour period of time, and with repeated dosing of those high doses, multiple doses for more than 24 hours. As a result, it is our general recommendation to consider the use of factor VII first for patients on Emisumab. In addition to the caution of the use of the choice of bypass therapy for a inhibitor patient on Emisumab, we also know that the measurement of factor levels while a patient on Emisumab can be problematic. The Emisumab causes falsely high levels of the APTT assay, as well as the one-stage clotting-based factor VIII assays. It's recommended that if you are looking to try to determine a factor level, you should use a chromogenic assay.
And Dr. Wynn, for those emergency departments that don't have recombinant factor VIIa, we would want them to use prothrombin complex concentrates in an inhibitor patient on Emisumab prophylaxis if they come in with a bleed. The point being that you would try to use the lowest possible dose to control the bleed.
So now we're going to move into our case discussions regarding how to manage these patients in the emergency room. Dr. Allen is going to introduce the first case and discuss it with us.
Okay, thank you, Dr. Nguyen. So this is a head trauma case, a pediatric case actually that just rolls into your emergency department. A 7-year-old boy, and they have a known history of severe hemophilia A. He receives factor VIII prophylaxis twice a week, and he tripped over a rock while running and he struck his head. Mother states he's been complaining of a mild headache, and his last infusion was about 2 days ago. Pertinent findings on exam: he's alert, interactive, he appears well. Vitals are normal on your first set of vital signs, and he's not in any distress. You don't even see a scalp hematoma, and his neurological exam is normal for age. So let's talk about some key questions. Is head imaging warranted? Does he need a factor VIII infusion? He uses a factor replacement at home, but mother does not have it with her. Your pharmacy only carries a different one. Is it okay to switch them? Thankfully, we've talked about a lot of these with the MASAC guidelines, and I think that it's really important to talk about how every patient represents a unique challenge, and a lot of these are going to require shared decision making. And this is something that I'm a real advocate of, and I try to do this with almost every patient that I have a discussion with in the emergency department when it comes to care options and potentially a safe discharge plan. And in this case with hemophilia in this patient, the individualization of care is recommended and encouraged. Here are some factors to consider for individualized treatment. With all these factors that you can see down here, it really underscores the need for shared decision making. So what are the goals of shared decision making? I think it's to impart knowledge and inform the patient, to activate the patient to increase the role they assume, which means that they have to be in the action phase for their own wellness, and to promote interaction between the patient and their healthcare professionals. And that may be you in the emergency department, but it also may be for their follow-up care with their specialist or if they require admission. So the National Quality Forum created a playbook for this. It's called the National Quality Partners Playbook. And to get through it and for some basic fundamental requirements for shared decision making, you want to think about clear and accurate and unbiased medical evidence. So you're sharing knowledge, and then the clinician expertise in communicating and tailoring that evidence for your patient. After you understand and are able to impart the knowledge of that evidence, you need to be able to communicate that effectively to your patient, who may have different levels of healthcare literacy. And furthermore, the patient's values, goals, and preferences have to be considered in these situations. I think we frequently encounter in the emergency department where patients may not want to follow your exact treatment plan, but your respect of their values and their goals in someone who has capacity should always be considered and encouraged. So what the playbook really encourages, as well as the AHRQ, is the SHARE approach. Seek their participation. Help them explore and compare options. Assess their values and preferences. You know, the social history is a big component of this. Reach a decision with the patient. Evaluate the patient's decision. And I would add a D to this: document. Document this discussion in your shared decision making, and this goes a long way to great charting, but also for continuity of care with that specialist in follow-up. So now back to that case that we talked about earlier. And we're going to talk a little bit about the management. As you know, we've talked about before, when in doubt, treat prior to seeking a diagnosis. And after shared decision making with the mother of the patient, we're going to administer factor to get them up to 100% because of their history of severe hemophilia. And we're going to talk about imaging because of the concern with the mechanism of injury where he fell and hit his head on a rock. And guess what? That CT shows a small subdural hematoma without a skull fracture, which makes sense with the physical exam findings of no hematoma externally. The boy is admitted to the pediatric ICU and serial exams and consult hematology while in the ICU. And this is a great strategy, and higher level of care is certainly encouraged in these patients getting factor and who have a known injury that you can then de-escalate as necessary after the necessary consultants are present. This leads us to our clinical pearls, and I want to bring in Dr. Wynn and Dr. Raj to really underscore these pieces of that last case and about shared decision-making together.
This is a great case, Dr. Allen. You know, it's an unfortunate situation that our families can find themselves in sometimes, but I think, you know, as you're highlighting, you know, good decision making can prevent, you know, further complications and worsening of the situation. You know, and I would highlight especially the decision to provide factor replacement for this patient early, when they arrive to the emergency room, and to do it before any imaging based upon the suspicion of the bleeding that the factor was given.
And Dr. Allen, I would add that with regards to shared decision making, it often goes a long way for the ER provider to contact either the patient's hematologist, if that's possible, or the hematologist on call at that institution, and for the ER physician to then say, we've discussed this with a specialist. And I think a lot of patients really appreciate that extra level of communication.
Those are both really great points, Dr. Wynn and Dr. Raj. You know, Dr. Wynn, this is bullet number 2 really underscores what you said earlier about when in doubt, correct to the appropriate level and assume that they're at 0. And Dr. Raj, you and I have done this frequently together, is have these discussions, and the peace of mind back to the patient and or their family member is really large and significant when we do have those discussions. And I can say, just like what you said, is I talked to Dr. Raj, your hematologist, and we're both on the same page with your treatment plan. How does that sound to you?
Absolutely. Well, let's move on to case 2, and letting the cat out of the bag here. It's titled Iliopsoas Bleed, but let's kind of walk through this as if you didn't know that. So we have a 28-year-old man with severe hemophilia A on prophylaxis with octocog alpha, but he missed his morning dose. He experienced left upper thigh pain after returning from a bike ride and administered his prophylactic dose of factor, but then the pain continued to worsen. And so he came into the ER with his home factor when he was no longer able to walk on his leg because it was just too painful for him to fully straighten the leg. So what are some key questions you should be asking yourself in the ER? Well, what is the suspected source of pain, obviously? What studies should be done, if any, to determine the source of bleeding? And what is the initial care provided in the ED? What should that look like? Should this patient be hospitalized or not? And what does continued treatment after the initial treatment in the ER look like? And what are the significant complications if we don't treat this patient in a timely manner? And then finally, most adults want to know when they can get back to normal and go back to work or school. So in this case, the suspected source of pain could be anything, and while bleeding is certainly high on the differential, we have to think of other things. In the case of a young man with pain in this area, we should be thinking of a hip joint bleed, a thigh muscle bleed, an iliopsoas bleed, which is a very specific type of bleed, as well as other non-hemophilia related disorders like hernias, testicular torsion, or epididymitis. The inability of this patient to extend his hip joint is highly suggestive of an iliopsoas bleed. And while you can, again, confirm this with imaging studies, remember, treating is paramount early on. Same thing with labs, those should not delay treatment. So importantly, if a patient is an inhibitor patient, you would use bypassing agents, and if they were a non-inhibitor patient, you would use factor. And as we've talked about before, if they bring those with them to the ED, you should use the patients if at all possible. And then one thing to remember about these specific bleeds in the iliopsoas muscle is that these are deep muscles and they can hold a lot of blood in terms of amount, and it sometimes is not noticeable until the patient clinically deteriorates. Often you'll have to use corticosteroids for paresthesias and pain relief. So in this case, again, having that iliopsoas bleed on the differential and just thinking about it is really critical. So in this patient, he received a factor replacement at 50 units per kilogram to bring his factor up to 100% for about 48 hours. And then he was kept on factor replacement to a target goal of 60% for the remainder of the week. A CT scan was eventually obtained after factor replacement and again confirmed what you suspected as an iliopsoas bleed. During periods of physical therapy, which this patient will likely require, it's important to maintain factor levels so as not to exacerbate bleeding and take 2 steps backwards. And in general, we like to keep factor levels around 60% during aggressive physical therapy. And once physical therapy is complete, the patient can then go back to their normal prophylaxis dosing. It's important that these patients also have strict bed rest initially, and ambulation should really be discouraged initially, even if it's with crutches, because any form of ambulation requires contraction of that iliopsoas muscle. So Dr. Nguyen, Dr. Allen, I know you've seen these type of bleeds before. Any thoughts that you have on these patients presenting to the ER with symptoms specific to an iliopsoas bleed?
Yeah, these are definitely sinister and can be certainly occult, but I really liked how we kept a broad differential diagnosis in the beginning to prevent from some diagnostic anchoring too, while still keeping that mindset of treat first, find a diagnosis later.
Yeah, I think the greatest point that this case highlights is to kind of keep a high index of suspicion for the bleed. So, and knowing kind of what the key physical findings are for how a iliopsoas bleed presents can be very, very important for an emergency room physician.
And importantly, sometimes when you give factor, it can be both therapeutic and diagnostic. So if it helps the patient after you give them factor, that's a clue that this really was a bleed and not something else that was not hemophilia related.
Okay, I will go ahead and start the third case. So our third case presents interestingly with a 15-month-old boy who is known to have severe hemophilia A, and he is experiencing a right knee bleed. You, as the emergency physician, know the family because you can remember when he comes to you that he came as an infant, and at that time he had a hemorrhage following a circumcision. It was eventually determined that he had hemophilia, and he was admitted to the hospital. And your memory of him is jogged by the fact that the family actually walked down to the emergency room and thanked you for helping them when he was discharged previously. So during this time, or since that time, he has had a port placed, and last week they began prophylaxis. The prophylaxis is with Maractocog alpha, and the patient has been receiving that twice a week. He received his second dose of prophylaxis this morning and then developed the bleed. So in this case, questions that we want to be asking are, what are the reasons why he is bleeding despite starting on prophylaxis? What are the risk factors that might cause an inhibitor to develop? To determine the inhibitor, what laboratory tests are important? How would this affect your treatment choice for the child's bleeding? And lastly, what does the family need to know in order to manage the inhibitor, for his early childhood and long term? So the outcome of this case, given the complexity of the presentation, you decide to go ahead and consult with the patient's pediatric hematologist. It's determined and suspected that he has an inhibitor, and in discussing the treatment options for bypass therapy, it was decided to go ahead and provide this patient with activated factor VII. So the patient was observed in the emergency room for 2 hours, and the parents note that he has improved. So he was eventually discharged home with consultation by the hematologist to have a very, very close follow-up and precautions on when to return for further treatment. So, Dr. Rajashekar and Dr. Allen, how do you think the management for this patient proceeded?
I think it was really important and critical that the ER physician, recognizing that this was not a straightforward case, involved the hematologist. And I think that's how we got to the diagnosis of inhibitor early on. It's important also to know that not many institutions will have inhibitor assays available in real time. And so one thing that can be done is looking at the PTT, and if it does not correct, you would expect in that case that this patient has indeed developed an inhibitor, as opposed to a patient without an inhibitor, in which case the PTT should correct on mixing.
Yeah, really great points, Dr. Raj. I think it's safe to say that any emergency physician would be anxious and a little nervous with this patient arriving to their ED. I think that the first bullet point with some reasons, and factor replacement, maybe it's been underdosed at home, maybe there's an issue there, but having that awareness that an inhibitor could be the etiology is why I think this is a big part of this educational activity that we're having today too, is to build that awareness around some of these things, and the whole mindset of treat early and consult early when you start to get into a potential predicament where it's going to impact their outcome.
And I think the fact that the emergency room physician consulted and brought in the involvement of the hematologist early on in the evaluation of this case is very, very important point to highlight. So to summarize our discussion today, the treatment of hemophilia has evolved, and it's evolved very, very rapidly and considerably over the past several years. The advancement in what we know has permitted the development of extended half-life factors, as well as its use in prophylaxis for hemophilia A and B. Newer therapies that look at rebalancing therapies for our patients also now exist. MASAC guidelines for treatment of hemophilia in emergency room does recommend that you treat these patients based on the suspicion of bleeding, and diagnostic testing and imaging it remains secondary in treatment. In regards to family members, remember that a shared decision making approach is very, very important, because our patients are very, very well educated in their disease, as well as to manage the bleeds that may develop. By listening to the family, you can arrive at a treatment much more quickly, and it will reduce the morbidity and mortality that could complicate the situation. Shared decision making will also increase the amount of treatment options that patients may know to be available to them, and it may actually be associated with increased health benefits. We wanted to take a minute to acknowledge the Hemophilia Foundation of Greater Florida. So the Hemophilia Foundation supports patients and families who have hemophilia and all bleeding disorders in the Greater Florida area. They provide all manners of support to these patients. To find out more about what the Hemophilia Foundation does, you can visit their website, or you can call their 1-800 number. So this ends our discussion for today. So thank you, Dr. Rajashekar and Dr. Allen, for your insights during our discussion. We hope that you found this activity informative and useful to your practice. And we also highly encourage you to earn extra credit by participating in PeerView's Optimal Management of Hemophilia in the Emergency Department Quality Improvement Module. Assess your practice, set your goals, and improve the level of your care for your hemophilia patients.
Thanks, everybody.
Thank you.
This activity has been jointly provided by University of Florida College of Medicine and PVI, PeerView Institute for Medical Education. The activity is also co-provided by Medical Learning Institute, Incorporated. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/QUN860. This activity is supported by an educational grant from Genentech.